Uh, it was a Senate bill, 128, passed in California in 2015, signed into law and enacted in June of 2016. So we have 8 years of experience with this law, and I can share with you some of its history, its organization and structure of what the law says needs to be done, and then some of the statistics as of the end of 2023 with what's happened in the first 7 years. This is my second part of a series. We started last week discussing end-of-life care in two parts. The first part was hospice and palliative care, and today we're doing the End-of-Life Options Act. I pulled over a couple of slides just to summarize the hospice and palliative care discussion we had, to remind those of you who were here what we talked about, and if any of you are here this week and not last, to explain kind of what we did in the first section of this. We spent a good third of that discussion about end of life, talking about dying being inevitable, but given the modern medical miracles that we can do, at times it seems as though it might be an option, and so many people believe that they're going to fight and battle and be able to overcome the odds and avoid dying, when what we all know is that we will all die. It's just a matter of when, not if. And there are two programs that medicine has designed to help people at the end of their life. The names of them are palliative care and hospice. They're two distinct, different programs. Palliative care is care that's concurrent with your disease treatment, and it tries to improve discussions about the goals that you're seeking, what you would like to see as this treatment progresses, and tries to help with better symptom management. And then hospice care, which is for terminally ill people at the end of their life, to help them and their family to ensure that a peaceful, meaningful death happens in their life. This is one of the diagrams I shared with the concept that you're getting traditional ongoing medical care for your illness, whether that's bad lung disease or heart disease or any type of malignancy. And then at some point, usually after you've been in the hospital on several different occasions, at the hospital, you will find a group of palliative care team that helps you understand the role palliative care can play and access their services, as well as palliative care services in the community, to add to your medical care. And then at some point, you shift over into hospice care. So those are a summary of what we did the last time. So today we're going to spend our hour on End-of-Life Options Act. Some people use the language of physician-assisted suicide, so I put that on here so that we can talk through the language also of what this is about. This is a summary from the California Department of Public Health that says the California End-of-Life Options Act authorizes medical aid in dying. The law allows a mentally capable, terminally ill adult with 6 months or less to live to request aid in dying medication from their doctor for self-administration. I would have put a period there if I was them, because I think that's the end of that phrase. If their suffering becomes unbearable, to bring about a peaceful death. The law was signed again in October of 15 and went into effect June of 16. The key parts of this, which we'll elaborate a lot on today, is a mentally capable, terminally ill adult with 6 months or less left to live can request aid in dying medication from their doctor for self-administration. Our country, the world, have had quite heavy discussions over who has rights to make decisions about life and death and choice. This could very well be a sign that you see today still out there, because the arguments over who has rights to make what decisions are still active throughout our country. Um, I'm surprised as I read through this particular talk, and then am seeing the parallel political discussions we're having now over abortion rights, to think about how and we make decisions, who makes those decisions, and how much medicine or government wants to get involved in all that. And it comes from a long history. There's certainly people now and historically who believe very strongly that no one should be taking the life of another person. That life is uniquely God-given, that life is to be preserved at all costs, and no one should take another person's life. About 30 years ago began a heavy movement in the United States, in particular to talk about quality of life, that an individual has a right to make a decision about their quality of their life, and take it upon themselves to end their life if they choose to do that. The picture here is Jack Kevorkian, who was very active in the original discussions and decisions, active during the early 1990s to be involved in helping people die, and he helped about 140, 150 people die during that time, felt it was an important part of medical care. He was a physician. He got arrested and charged with murder because of all this. So we've still debate today these issues, and I want to share at least that part so that you can understand the state you live in, the legal issue, and why it's a legal discussion about the end of life options. End of life decisions in general are interesting when you think them through. We have three main sort of things that come up to create the end of a life of someone. Murder's a pretty obvious piece in which one individual decides that another individual shouldn't live anymore and takes their life for whatever reason they choose to do that. Mercy killing is the language used when a typically healthcare professional makes a decision that this other individual is suffering too much and takes their life without the consent of the individual whose life they've taken. And then the third of suicide, where an individual says, I'm going to take my own life and commit suicide. All three of those words and actions are illegal across the United States. No one would accept the concept of making legal murder, mercy killing, or suicide. In the health world, we have accepted an idea of do not resuscitate and no CPR, that individuals have the right to say, I don't want the medical care you're offering me, and I do not want to have resuscitation or CPR, and that's perfectly legal and is accepted and practiced across the United States. There's not a hospital, there's not a religious affiliated institution that will not accept a do not resuscitate, no CPR. So it has become pretty standard. We have forms that people fill out that say they don't want those particular types of medical care provided to them. We've also pretty much accepted across the country withholding or withdrawing treatment. So withholding treatment is an order that would come from a patient that says, I don't want you ever to intubate me, to put a tube in my throat and hook me to a breathing machine. Withdrawing is, I've been hooked to a breathing machine and I don't want it anymore. And I have filled out paperwork that says, please remove a breathing machine from me because I don't want that. So standard across every institution of healthcare in this country, withholding and withdrawing treatment is standard care and can happen. It does obviously depend upon the individual's desire, the completion, I hope, of advanced directives and durable powers of attorney for healthcare. But no one would claim that do not resuscitate, no CPR, or withholding or withdrawing treatment is in any way illegal or justified for any sort of legal action. We've used both of those to deal in the world of brain death and organ donations, where individuals who've suffered either brain death, where we can determine the brain is no longer functioning, or they live in a what's persistent brain injured state, severe enough that the discussion is for them to have their ventilatory support withdrawn. And before that happens, organs are donated from their body. All three of these are very different than the ones above. They're all legal, they're all accepted almost entirely across all the United States. And then we have assisted suicide. An assisted suicide is where the End of Life Options Act has taken over and made it legal. In the state of California, it's not considered murder or mercy killing, and it's differentiated from suicide. Again, I'm going to pull that language from what the California Department of Health said. A mentally competent, terminally ill patient may request aid in dying medicines from their doctor for self-administration. Sometimes referred to as physician-assisted suicide, since the medicines come from their doctor. And that's where the legal part of all this comes in, that the patient's mentally competent and terminally ill. Two resources I would point you to at the beginning that are going to help me talk about this. The second one is the California Department of Public Health, and I've referenced already the language they put out that I've read to you a couple times now. They have the website that collects all the data and all the information. You can read all the forms that are required from that website. So it is one of the best resources to go to understand this further. But I listed first the organization called Compassion and Choices. Compassion and Choices is a fascinating group organized in the United States out of a prior group that Kevorkian was part of. Dr. Kevorkian and Derek Humphreys are two individuals who were active and created an organization called the Hemlock Society back in the 80s. And after Kevorkian went through his processes and his charges in the 90s, an organization sprung up out of the Hemlock Society that said, we've got to come up with a way to make this assisted suicide, physician-assisted suicide, legal, so that nobody is charged with murder. And what they did, and the Compassion and Choices organization has lots of membership that is involved in the legal profession. is they developed and wrote the laws that have gone to a number of US states and convinced the state legislatures to pass laws that allow this to be legal. They began this in Oregon. And Oregon was the first state in which the concept of end-of-life options, or the language of death with dignity, was first made legal. California and Washington followed, Washington first, California second. It has now been passed in legislation in these 10 US states: Hawaii, Washington, Montana, Oregon, California, Colorado, New Mexico, Maine, Vermont, and New Jersey. Part of this is also in Washington, D.C., even though Washington, D.C. is not a state. And Montana legislation passed similar law, but not exact law that the other states have passed. But the law in across all of these is so similar that if you speak about the legal aspect of it in one state, it's going to carry over to the other state. Here is an interesting graph from Compassion and Choice's website that shows you what we just did. If you look in red, these states all have laws that allow physician-assisted suicide to be in place. But I want to point out the 11 green states that have all passed laws against physician-assisted suicide, and those are new laws and the dates at which they passed them. The blue states have laws already on the books. They didn't need new laws. Laws already on the books that banned physician-assisted suicide, and they're still in effect. Like I mentioned, Montana has a funny law, but it does have a law that allows physician-assisted suicide. And then there are 2 states that don't have anything written in their legislation. So what this map shows you is that we're a divided country on this issue. Very much like what I put on the slide with thou shalt not kill and quality of life. There are quite discussions and arguments over the rights and wrongs of physician-assisted suicide. The Compassion and Choices organization that helped write the laws, again, very similar laws in all of these states, continue to adjust the law, going back to the states with some recommended changes, and to go after any of the other states that they feel they may have an ear in the legislation and the legislators of that state to create a law to make this acceptable in their states. I have not heard about any national discussion over anything from our federal government to change the states' rights to make these decisions. As you know, that was a huge issue in the abortion discussion. So I don't know where that'll go through our lifetime. Right now, today, this is the situation. And now I'm going to focus primarily on the law in the state of California. But what I have tried to already say is the law you have here is the same as the law in almost all those red states. So what needs to happen? What's the law say? The patient has to request an end-of-life option process, and they have to verbally request it and request it in writing. The doctor then needs to determine, is the patient qualified to receive end-of-life medicines? They have to inform the patient of everything they believe is wrong in terms of the specifics in the diagnosis, the prognosis, all the options for the patient. They have to ask a second physician to be involved. so that the burden of making this decision is not only on one doctor, but there are two physicians to determine if the patient's qualified. Then the patient receives specific counseling, and there's a form that the doctor must fill out, check off boxes that say, I've counseled them about these issues. I will show you those forms. There is a final attestation by the doctor that he or she have done all of these, that the attestation says the doctor knows the patient has requested this in verbally and in writing, that the patient's qualified, that they fully informed the patient, that they've had a consulting physician and done the counseling, and then the doctor can write the prescription. The patient gets the prescription done, filled out, and makes the decision on how they want to proceed. The doctor then completes any and all the follow-up forms and reports it to the California Department of Public Health. So let's spend a little bit of time on, is the patient qualified, and the doctors giving the patient the information. To be qualified, the patient has to be terminally ill. So that's one of the key aspects of getting this law passed, was to say this is nowhere near the concepts of murder or suicide. This is a patient who's dying, and they have a life expectancy of 6 months or less. If you were with us last week when we talked about hospice care, I spent quite a bit of time trying to define for you how doctors determine if a patient's terminally ill. It's based upon their diagnosis, based upon their other disease processes, based upon the functional level that they're at, and then their desire to not seek further treatment that allows them to be eligible to enter hospice care and to be terminally ill. So a patient to qualify for End-of-Life Options Act has to be terminally ill. They have to be a resident in the state of California. Does the last words there get covered up because of my thing here? Because it's covered up on mine, so I'll move that. Maybe that helps. They have to be a resident in the state of California. In fact, all the laws across all the states say you have to be a resident of that state in order to get your End-of-Life Options Act medications, except now both Oregon and Vermont have dropped that law. Oregon, which again started the legal process and was the first state ever to have a End-of-Life Options Act, a Death with Dignity Act passed, has made the decision, along with Vermont, to eliminate residency requirements. You may be aware of a large discussion about how people moved into Oregon in order to establish residency requirements to get medicines there, but no longer do those two states require that. They believe, and this came from Compassion and Choices, pushing them to believe that law, that residency requirement made no sense, that there was no reason to have that as a barrier for people seeking this medicine. Okay, there we go. Again, terminally ill, mentally competent to make medical decisions. One of the issues in getting this law passed was to make sure that the patient was the one making the decision that they wanted this, and that this patient was mentally competent to make that decision. This cannot be done by a durable power of attorney. It cannot be done by an advance directive. The patient themselves must request and complete forms that this is what they want. They have to be acting voluntarily, and there has to be witnesses to the request that document this is a voluntary action of this patient. Seems complicated, seems like a lot of things, but the issues are, we live in a contentious society, in which murder, mercy killing, suicide are all illegal actions. So there needed to be a way to differentiate this to make it not illegal. And that's what the law has created in our state. And so the patient has to be mentally competent, terminally ill, and acting voluntarily. They have to be capable of self-administering the aid in dying drug. This is a very complicated piece of this law, in my opinion, because I don't know a single physician who has denied anybody this medicine if they would have written it before because they didn't think that they could take it themselves. I also don't know of any prosecution that's happened where someone else has assisted in providing this patient the medicine. But it's a little sticking point in this law to me, that the physician needs to be able to say they believe the patient is capable of self-administration of this drug. Fully informed of the diagnosis, the prognosis, how this drug works, the risks, and ensure the patient understands they are not obligated to take the medicines you're going to prescribe, that you're doing this at their request, but even when they get the medicines, they're not obligated to take it. Then there's a physician form that documents all this. The patient request has to be made by the patient with the disease, cannot be made by anyone else. No power of attorney, no advance directive, no conservator. No one else can make this decision. This is the issue, these two pieces that make it impossible for dementia patients to get these medicines, because a dementia patient is not terminally ill until late in the disease process, at a point at which they cannot be mentally competent to get medicines from their doctor, and there is no provision that allows a other person to get that medicine. The Compassion and Choices recognize this is a loophole in this law, and it's one that they couldn't get around in any way to allow a legislature of people to pass. So right now, dementia patients are ineligible to get this medicine. The first change in the law in California happened 2 years ago when it changed and said that the patient has to make 2 requests for the drug 15 days apart, and now lessened that to 48 hours with a new Senate bill. There still has to be 1 written request, and there has to be 2 witnesses to that. The witnesses are an interesting portion. The attending physician, the consulting physician, or a mental health specialist for the individual cannot be a witness. So you need other than the physicians or mental health professional to be a witness. Only one of the 2 witnesses can be related to the individual. And you cannot own, operate, or be employed in a healthcare facility where the individual is receiving medical treatment. Only one individual can be that. So usually the 2 individuals are a relative and somebody where you're living. You must document if there's an interpreter involved in this process, and the interpreter has to document that they have been involved and that the discussion has been as written. The referral to the consulting physician. A consulting physician means a physician who is independent from the original attending physician and who is qualified by specialty or experience to make a professional diagnosis about the terminal status, the prognosis of this individual's terminal disease, and their mental capacity. And there's a form for them to fill out. Patient counseling, here are some of the details. When you have this medicine and you intend to ingest it, you must have another person present. You should not be taking this medicine alone in a room because things can happen. So having another person around is an important point to make as people are considering taking this medicine. You can't use aid in dying medicine in a public place. It has to be your own private location. And that's part of the check boxes that doctors have to check off, that we've told you you shouldn't be ingesting this drug in a public place. We check off that we have told you you should be notifying your next of kin. We're not required to notify them. We're required to counsel you that you need to be notifying them. We're counseling you that you should be participating in a hospice program. It's not a requirement to get the medicine, but again, all of these are counseling check boxes that we're supposed to explain to the patient. It goes along with getting the prescription, and that you understand we have counseled you in this regard. You should get this medicine and keep it in a safe and secure location. No one else should have access to it. You can at any point change your mind. You don't need and you're not obligated to take this medicine at any time or in any manner. You have an opportunity to withdraw or rescind the request. You cannot take the prescriptions, you cannot get the medicines, and you don't need to take them even if you get them. So an individual is being told and counseled in this manner so that they do it totally voluntarily and they recognize they're under no obligation. The attending physician must verify immediately before writing the prescription the patient is making an informed decision. So we're again trying our best to protect physicians, saying, we have counseled you and you're making an informed decision about what this medicine's you're going to get is going to do. We have a checklist. We used to have what's called a final attestation form, and the state got rid of that. We then can write the prescription, and it's the primary doctor, not the consulting doctor, who writes the prescription. And that prescription can be written in a variety and obtained by the patient in a variety of ways. We can directly via phone or via email contact the pharmacist. We can do what's called electronic prescribing that allows us to access the pharmacy's records and put in a prescription for you electronically. We can hand you the prescription. We can mail in a prescription. The physician themselves can give you the medicine if they're authorized to dispense medicines. Now, most physicians in California do not have authorization to dispense medicines. It's a rare physician, usually in rural areas, because it's hard to get the license to prescribe drugs from your office to give out drugs. So most doctors don't have it, but there's nothing in the law that says that you can't do that. And the pharmacy can give the meds directly to you, or interestingly enough, the law says the pharmacy can give that to another person. The pharmacy could mail you the medicines. There's nothing in the pharmacy law or in this law that prohibits the medicines being dispensed to you in some other way. Through your loved one, through a friend who's picking it up, or even, again, being mailed to you. What are the medicines? What are we prescribing? Well, you begin with a prescription for something so that when you take the aid in dying medicine, you don't throw it up. So we pre-medicate people in the neighborhood of 30 to 45 minutes with an anti-nausea medicine or an antiemetic is the language. The two we use are Reglan, which is metoclopramide, or Zofran, ondansetron, or ondansetron, and you pre-medicate before you take the medicine. We advise you that you should not be having fatty foods prior to using the medicine. Again, just anything to do that those foods might still be present and absorb the drug, or that they might make your stomach upset. The medicine is usually either powdered or already mixed into a liquid. They're not individual pills. The liquid can be put into any liquid you want, can be put into applesauce that people take. What you shouldn't do is mix it in a quart of liquid. You shouldn't mix it in a bottle of applesauce. You want to put it in the smallest volume you can put it into, so that you can get it easily down. And you should consume the slurry of medicine pretty quickly, because it has medicines that are going to make you pretty tired pretty quickly. So we don't want you trying to drink this over the next half hour. You should be able to drink this medicine down, or if it's in applesauce, eat the full thing of applesauce that you have it put into. There's nothing special about applesauce. You can use cream of wheat, whatever you would like. But you want to consume the amount that has the chemical in it in a fairly reasonable time. After you've consumed it, you can drink some liquid. The taste sometimes of these medicines isn't good, and people want to have either another sip of water or a sip of whatever they would like to get the flavor out of their mouth. And death usually happens in about 30 minutes. There's a range. It just depends on the individual, depends on the drugs being used, and you die because these medicines stop your body from breathing. This is a list of the medicines. Originally, the Death with Dignity Act, DWDA medications. This is what's gone on through the years, started by using the heavy barbiturates, secobarbital or pentobarbital. However, both of those have become unavailable. So Oregon was one of the few states where those medicines were used quite a bit, because it started the law when those medicines were still available. The medicines being used currently across the various states vary by which doctor's prescribing them. There's no requirement that an individual use this medicine or that medicine, and they're all combinations of medicines. The last one, DDMAPH, is the currently most common one used. But the combination includes a medicine called diazepam. That's in all three of those. That's the first D. And digoxin, that's the second D. Diazepam is Valium. It's a barbiturate, it's a benzodiazepine. It creates amnesia and it creates sedation. Digoxin is a heart medicine that at the doses prescribed will slow the heart rate down considerably. So the first two Ds are diazepam, Valium, and digoxin, and they're in all three of the combinations. The third M is in all three, and that's morphine. And morphine powder that is combined into a liquid is given again as a sedative, as a comfort medicine. And so morphine is in all three of the formulations. The DDMP used another drug as its fourth drug called propranolol, which is another type of drug to slow heart rates down. So the diazepam and the morphine suppressed respiration, and the digoxin and propranolol slowed heart rates. DDMA used amitriptyline instead of propranolol. Again, another thing to slow a heart rate down, but also it's pretty toxic to the heart, so it creates abnormal heart rhythms at the dose it's given. DDMAPH, the last one on the list, has amitriptyline in addition to digoxin for the heart, but also adds another barbiturate, phenobarbital. And again, as I said, that's the most common one used. Here's a graph of their uses over the years in Oregon. You can see secobarbital and phenobarbital or pentobarbital early on. You can see the beginning and them stop. There is no use after 2019 of those drugs. The DDMP, the DDMA, and then the DDMAPH being the currently most commonly prescribed combination being used. This is Oregon data. California has not released similar data, but I believe DDMAPH is the drug of choice in California by California doctors. This is an interesting table from Oregon that talks about how long does it take from the time you take this medicine, ingest this medicine, and death happens. And this is 22 years of data from Oregon. So it's pretty good history. The drugs used on the left-hand column, the total number of times that particular combination has been prescribed, the number of patients, we don't know how long it took them to die, and then the column that says we know how long it took these people to die. So of the 2,700 who got prescriptions, the bottom of the total column, we know the duration of death in 1,500. You can see how many died under an hour, between 1 to 6 hours, or more than 6 hours. And the median and the mean, I'm not sure if you can see the mean because it seems to me it's covered up here, but so that's the mean number. There we go. I moved that to the top. That's the mean number of minutes that it takes an individual to die. The median, meaning most people die in this time frame. So you can see it can take 60 minutes and an hour, 5 hours as the mean number by using DDMP. The 1s and 2s are just different strengths of the medicines. So you can see that, as I mentioned, the DDMAPH is the one being used mostly, and most people will die short of right around an hour, and the mean number is a couple of hours. Then physicians are required to submit documents after the patient's died to the state as best they know. That should be submitted within 30 calendar days to the California Department of Public Health. One of the things that's in this law that's really important is that the law states the patient has the right to this option and that their death is not a suicide. That's important. Their death certificate says they were terminally ill from this disease. And the reason that's important is that both health insurance and life insurance must cover the medical costs related to this. And in suicide, life insurance doesn't need to pay out. In suicides, if there are incurred expenses related to an ER visit or a hospitalization, those are not covered by people's health insurance. So this is not a suicide. This is a physician-assisted suicide, and the death certificate reads the terminal illness is what caused your death. There are some interesting pieces to this for physician rights. And it says no physician must participate in this. Any physician who feels uncomfortable may opt out of participating, and you cannot sue that physician for opting out, and the physician does not lose their license for not participating in this. So they gave every California physician, and again, in all the states where this is law, the physicians the right to not participate. Physicians are also protected from any lawsuits or censures by states or individuals if they do participate. Now, there are organizations that employ physicians, and those organizations can choose to say their employed physicians may not participate in this. So the local example of that is Dignity Health Systems employ doctors to practice medicine in offices, and they do not allow those physicians, while they're being employed by them, to participate in prescribing death with dignity drugs. So the employer has the right to prohibit their employee doctor from participating in this. Can the doctor on their own time participate? Absolutely, as long as they have an employee status that recognizes their own time as separate. There are felony prosecutions that are possible in this law for forging or altering a request or destroying the patient's withdrawal of their consent. So that makes sense. If you as a physician are going to forge any of this paperwork, or you're going to alter the request that a patient's made, you could be prosecuted. Coercing any individual to take the medicine is illegal. Assisting the patient in the ingestion. This is the piece I put up at the earlier slide and talked about, where it's supposed to be and written in the law that the patient self-administers this medicine. That assisting the patient or giving the patient the medicine in some manner is not legal. Giving meaning it's a slurry of medicine the patient can't swallow, and they have a G-tube in place, and a different person pushes the medicine into the G-tube. That would be considered assisting the patient in the ingestion, and that individual could be prosecuted. Here is the California 2016 when it first went into effect, and up to 2023 use of this law. By year, how many people got the prescription is the blue, how many people took it. And you can see, and of course would think that there might be some delay. You're going to get the prescription in October, November, December, and not use it until the next year. So there's always going to be a little lag potentially in the number of prescriptions written and the number taken. There's also people who get the prescription because they want to know they have the option and have the prescription, but they don't want to take it and don't take it. So the separation of these two graphs is understandable. And you can see the experience in California of how many people have had it and taken it. This jump in 21 is interesting. I don't think anyone's explained quite why that happened. You might think through COVID, you might think through the situations that have gone on in our country in those eras. I don't know, and I don't have an explanation, nor do I know anyone who has. So totally, there have been 6,516 prescriptions and 4,287 people who have taken them and died from them. This is last year on the California Department of Public Health. They post all kinds of information. I thought this was interesting. Last year, 1,281 individuals had prescriptions written. And we knew that 835 of them ingested them and died. We don't know what happened to 276 yet. We don't know if they still have the medicines or they chose not to take them, or what's going on there. And may still take them down the line. 170 people got a prescription but died, otherwise didn't take it. And there were 49 people who had prescriptions from 2022 who took them and died in 2023. So the total number of people who died as a result of ingesting the drug died in 2023. Here are some issues that are going on with this act. Finding a doctor who's willing to participate in this isn't simple. In California, in particularly rural communities where there's limited numbers of physicians, there may be no physician in that community willing to participate. In Ventura County, I know of one doctor who has now advertised on their website that they are willing to participate for any patient who wants them to be involved. And I know about a dozen doctors who are willing to write prescriptions for their patients they take care of. And so finding a doctor who is willing to participate can be a problem. As I mentioned, some institutions have prohibited their doctors, and some patients, physicians are not willing to do this. And so it is an interesting time still to find a physician willing to participate. There's the second bullet point where I've mentioned again that corporate policy prohibits certain physicians. The third bullet point is there's really no standardization of what medicines are used. If you're involved in this and you've read through the literature as a physician, you will quickly figure out what medicines you should be using as the most likely drugs. But it certainly isn't part of the law, and it isn't like there's a standard of practice in medicine that this is the drug you have to use. And again, as I mentioned, there's no exceptions for patients with dementia, so they still remain a problem. So physician-assisted suicide, mentally competent, terminally ill patients may request aid in dying medicines from their doctor to self-administer those drugs. That's the End of Life Options Act law, and I'm happy to answer any questions anyone has about it at this point.